Good evening, and welcome all to tonight's webinar series brought to you by the Mount Sinai Hospital, Marie Josie and Henry R. Kravis Center at 85th Street. I am your host, Frank Barra, and along with me as panelists will be Janet Johnson, DNP, who is the clinical director of our center, Marnie Friedman, a registered dietitian, and tonight as our guest presenter, we will have Dr. Judith Goldfinger presenting her topic in hypertension, detect, correct, and protect. Dr. Goldfinger is a clinical cardiologist at Mount Sinai West and the director of vascular medicine, part of Mount Sinai Heart, under the leadership of world-renowned cardiologist Dr. Valentin Fuster. Her practice includes cardiology and vascular medicine, and she also focuses on wellness, women's health, and preventative cardiology. Dr. Goldfinger graduated cum laude from Columbia University. She matriculated at Icahn School of Medicine at Mount Sinai, from which she graduated in 2007 with distinction in research after completing a Doris Duke Clinical Research Fellowship. This was followed by residency in internal medicine at the Mount Sinai Hospital. Dr. Goldfinger stayed at Mount Sinai for cardiology fellowship, including 1 year as chief fellow, followed by vascular medicine fellowship, which she completed in June 2015. Dr. Goldfinger is an assistant professor of medicine and cardiology at the Icahn School of Medicine at Mount Sinai. Dr. Goldfinger is also board certified in internal medicine, cardiovascular disease, echocardiography, and vascular ultrasound interpretation. Dr. Goldfinger is certified by the American Board of Vascular Medicine and is a fellow of the American College of Cardiology, member of the American Heart Association, and member of the Society for Vascular Medicine. Dr. Goldfinger, we welcome you tonight. Thank you for joining us.
Thank you. So just remind me, if people have questions, I won't be able to hear them. They'll just go into the chat.
They will go into the chat, yes. So for anybody who has a question, type it in. We'll try and address it. If you don't, we have a survey at the end of the webinar, which we will try and answer your questions and email you back. So with that said, Dr. Goldfinger, the room is all yours.
Yay. Okay, so I'm gonna start kind of broadly, and then based on questions or interest or whichever way we go, I think we can sort of reorient ourselves. So hypertension, which is high blood pressure, is a huge topic. There is a medical journal called Hypertension. Then there are many other medical journals that cover many aspects of hypertension. And so some of what I wanted to do was just give an overview that's not too basic, and then talk about some of the interesting things that have come up in the past year. So even if you've been to a high blood pressure talk recently, there's always something new. And then we're blessed and lucky to have a nutrition expert on the call, as well as an exercise expert, as well as Janet, who's an all-around expert. And so we'll be able to sort of, she is. We'll be able to sort of pull expertise in all sorts of different directions, which for this topic is super relevant. So one of the most interesting things is how the definition of high blood pressure has changed from the time I was in medical school, but I hear this from patients all the time. When did it happen that, quote unquote, all of a sudden a blood pressure above 130 is considered hypertension? And people are right, in the same way that the goal for sugar has changed, the goal for cholesterol has changed, the goal for blood pressure also changed. And it didn't come out of sort of this desire of doctors to punish people, I guess pharmaceutical companies. All of this has come out of research trials that over time have found that as you push the blood pressure lower, and that doesn't mean to zero, nobody wants a blood pressure of zero, but as you push the blood pressure lower, you see an improvement in health outcomes. And when we say health outcomes in the world of blood pressure, we're talking about all of the things that blood pressure is a risk for. So heart attacks, stroke, heart failure, meaning the heart can't pump well, kidney disease, meaning the kidneys can't filter well. And one of the hot topics in blood pressure is dementia or cognitive issues. And over the past few years, more and more studies have looked at how controlling blood pressure can help in terms of cognition, preventing progression to dementia. So, when we talk about blood pressure, it's not that the blood pressure in itself is the problem. It's that having a blood pressure that's high meaning being in a situation where your body's the pressure at which it's circulating blood is high, puts all of these organs at risk for damage. And if you ever want to Google something charming, if you go to the American Heart Association website, they have this cute picture that I should probably Google right now and show everybody, but this cute picture of all of the organs that are affected by blood pressure. And usually the one that everyone zeroes in on is erectile dysfunction. So I guess just the men, but having uncontrolled blood, maybe someone, I don't know, having uncontrolled blood pressure is a risk factor for erectile dysfunction too. So even though everyone talks heart attacks and strokes, you always have to find the piece of the thing that appeals to people the most. And so over time, what we've learned is as you get the blood pressure better controlled, the risk of all of these complications is reduced. So a few years ago, there was a huge trial called SPRINT, and I know probably this is too much medical ease, but it's famous in the cardiology world, that basically said, let's see what happens if we get people's blood pressure less than 130 versus people who are, controlled but allowed to be above 130. And the group that was under 130 had less heart attacks, strokes, but the big differences were congestive heart failure and kidney issues. And so that sort of moved, and ultimately death. And so that sort of moved all of our goalposts where we say, wow, if just making that sort of not necessarily major change in blood pressure can have such a big health impact, that's where we want to go. And so then, usually the next question is, okay, how are we going to get there, right? And when I am seeing patients, if the blood pressure is 200, it's a very different conversation than if the blood pressure is 144. So if the blood pressure is 200, first of all, the risk is bigger. Second of all, I don't feel as comfortable, sort of pursuing the lifestyle stuff, and then medication becomes more important. But for most people, when you see a high blood pressure, your first response is, what can we do in terms of diet and exercise to improve the blood pressure? And this is where Marnie comes in and where Frank comes in. And I guess we'll do both individually. Sometimes in the medical counseling, we're a little too quick, including me, to just say, oh, you need to eat better to get your blood pressure better. But I'm wondering, Marnie, if you'd want to just maybe give sort of a little bit of an overview, and then maybe we can do some back and forth on specifics that I get asked about all the time.
Definitely. So for the most part, what we recommend for, hypertension and just in general for heart healthy diets is a diet that's rich in fruits and vegetables, a diet that's low in sodium, a diet that's low in processed meats, and a diet that's rich in whole grains. But that's sort of general and, based on each person and their preferences. I think a lot of what I do with patients is sort of individualize and make it, work for them and their lifestyle, including their culture and, their different foods that they like.
So one of the interesting things that came out this year, and I don't know if you saw it because it just came out, but Jane Brody covered it. So as soon as Jane Brody covers it, we'll all be talking about it. Like she just covered aspirin. So now yesterday, everyone's talking about aspirin. Was this trial in different villages in China where they gave half the villages regular salt, and the half the villages, they gave this version of salt that was only 70 or 75% sodium and was 25 or 30% potassium. Mm-hmm. And just with that reduction, meaning people were still using MSG, soy sauce, whatever, all that was changed was the table salt. And with that change, they saw at 5 years a decrease in heart attack and stroke, which is what they were trying to see. So the cardiology world sort of exploded at this because finally there was a trial that really compared salt to salt reduction, in one specific way. But I've been getting questions from patients that are like, where can I find a 30% potassium salt? And I'm like, that's not the point. Yeah. But I think it's sort of like a food for thought. So if, just in the framework of that trial, like that Jane Brody covered in the New York Times, what's sort of like a way you would adapt that for a patient?
Yeah, definitely. So I am not familiar with any product, like you said, a soda.
I don't think it is.
Yeah. But that, I think you can sort of add fruits and vegetables and get that same effect. So foods that, have potassium, or, foods that are rich in vitamins and minerals. I think that's sort of sounds like to me, I'm not super familiar with that study, but I'll have to look into it.
More the concept of it. Yeah. Like,
yeah,
how
but
to
it sounds
adapt
like
the
to me, it's just
concept.
sort of, it sounds like to me, it's just more, the fruits and vegetables and having maybe more minerals and vitamins in the diet. Rather
Can
than
I
sodium.
jump in here? So
Totally.
I think one of the things that people aren't familiar with is really looking at the label and seeing how much sodium there is in product. When I started, teaching a little bit more about, low salt diets to when I was working inpatient, I became a label reader. And for example, all the nurse practitioners were on diet. So in our refrigerator, we had a low fat Caesar salad dressing. I was thinking that was great, but it had for a tablespoonful, which was the serving size, it was something like, 300 milligrams of sodium. So maybe Marnie going through, so what is a product or serving that is okay in sodium, and what is a high sodium product? Of course, so people can look at labels and then identify that part of it.
Yeah, definitely. So I think anything under sort of 200 milligrams in a food item would be something, good to look at, but really, if it depends if it's a snack versus if it's like a full meal. But ideally for most patients, it's around 2000 milligrams or less for the full day. So a lot of times, like with canned products, or like you said, with things that come in containers, we can then look at the label and adjust. But, of course, when you're cooking or preparing foods yourself, that would sort of be, adding salt to the foods, and rather than just the canned foods that have the labels already.
Part of it is like this perception that you're thinking of food as salty. So, like chicken soup, you think of as like a salty food. And then salt is used as a preservative in so many foods, and people just don't even have an awareness. So like so many frozen meals have so much salt. And if you're somebody who has high blood pressure, you don't have an awareness, you would never even think to check. I think there's sort of these things like canned soup is a good example. But then you realize so many baked goods. And then usually when I point it out, people will say, oh, but it's not even salty. And I agree with you. That's why, if in an ideal world where you could do whole grains, fresh fruits and vegetables, foods that don't have these additives. And part of the interesting thing for me has always been, I now have like a not small group of people who lived at the border of high blood pressure, and then with careful diet end up not really having high blood pressure, and then you realize it's sort of this like constant tension. Like if those people then go back to eating, I don't know, I guess your Caesar dressing, but it doesn't really take that much to sort of push you over the top. So, so like if I see somebody in the office and the blood pressure is high, in the same visit where I start talking diet, exercise, sleep, eating more potassium foods instead of sodium foods, staying hydrated, in that same visit, I also start talking about checking blood pressure at home. So everyone is very familiar with white coat hypertension, or at least they've heard the phrase. I would say probably half of the people that I see every day say to me, oh, my blood pressure is just high because I'm in your office. Then I always say, oh, what is it at home? Then most of them say, oh, I've never checked it at home. So then I say, oh, so where is it normal? What do you mean? So I said, well, it's high in my office, but where is it normal that we can say it's just high because it's white coat? And then most people say, huh. All right. So, but the point is valid, meaning there are people for whom the blood pressure is substantially higher in doctors' offices. There are people for whom the blood pressure is a little bit higher. And some of it comes into this question of, are we checking blood pressure correctly in doctors' offices, which Janet knows is like in my top 3 conversation to have, which I guess is a strange thing to have as your top 3, but anyway. And so I usually encourage people to get a machine, not a wrist cuff, only because wrist cuffs are so sensitive to position. So somebody who has a very large arm that doesn't fit an arm cuff, sure, yes, wrist. Otherwise, I encourage people to get an arm cuff, and I usually spend a good amount of time telling people how to check blood pressure at home so that it's accurate. And it's funny, every time I like type this up in the patient instructions, I like how my hands look monstrous in this. Every time that I type it up in the patient instructions, I think I should really save this so that I could just copy it, but I haven't done it yet, so I probably will never do it. But the correct way to check blood pressure in a doctor's office or at home is sitting for at least 5 to 10 minutes in a chair that has a back with your feet on the floor, your arms supported. And the idea being, there's actually a cute table somewhere of like how if you don't do each of these things, it can potentially add like an error of like somewhere around 3 points. So you say, okay, 3 points is nothing, but I guess if you're doing all of those things, you end up 15 points off. And then where are you? What were you going to say?
So we do have a question that came in regarding sodium and potassium, which we were just talking about. And the question reads, why is it potassium versus sodium? Do they taste alike? Do they both flavor foods the same way?
So it's probably because on a cellular level, there's a sodium potassium exchange that happens. So eating more potassium can actually lower your sodium. But I think in terms of the salt, the real answer is because they're both positive ions. Sorry, but that's the real answer. So it doesn't affect the chemical makeup of the salt to just swap out a sodium for a potassium. Interesting. Done in China. Everyone keeps saying, do you think in the United States they could take 300 villages and give those 300 villages like a substitute of table salt and just be like, go?
No.
Right? But they used it. I mean, they did it. Even the people who didn't use it hold no, right? But it had enough of an impact that you could see a difference in heart attack and stroke, which is amazing. But back to my blood pressure. So sitting in a chair with a back, feet on the floor, arms supported, cuff on the bare upper arm. And if you get a high reading, the most important thing is you sit for another couple of minutes and see if it comes down. And many people have had that kind of experience where they've been in the doctor's office, the blood pressure is high, and somebody said, oh, you know what, sit for a few minutes, we'll see if it comes down. And then it comes down and they say, oh, you know what, sit for another few minutes, we'll see if it comes down. And what you're trying to get to is the true resting blood pressure. So there are people who are not in great shape, let's say, or the doctor's office is all the way down a long hallway, like some of the cardiology offices in the main hospital. And people are really trekking to get into the exam room. So by the time the blood pressure is measured, it's really an exercise blood pressure. And so you don't want to be making medication decisions off of a blood pressure that's not accurate. If you have somebody who's home and measuring their blood pressure in a regular ongoing way and they're getting numbers that are very different, that's meaningful. And I will usually tell people to bring in their machine so I can check it just to make sure that what I get in the office matches the machine in the office. If it's accurate in the office, I don't care if it's higher. So, if you're getting readings at home of 125, you bring it into the office, I'm getting 160, your machine is giving me 160. The takeaway is not, oh my God, it's 160. The takeaway is the machine is accurate. Now we can trust whatever we get at home. And so that really informs things. Does that work for every doctor? No, I'll still get messages. Oh my God, the blood pressure is so high. And then you just have to say, I'm not really worried about it because it's controlled at home. We know the machine is accurate. We don't need to worry about all of these health effects. Hopefully this person is not spending, too much time at home, too much time at the doctor. Frank, in terms of exercise, if you were seeing somebody who, the isolated thing was blood pressure is high, we want to get this person exercising to lose weight and improve blood pressure, where would you focus first?
So the first thing we would focus is on trying to get them to be a little bit more active throughout the day. We would obviously have them participate in aerobic exercise training. We've seen after 20 minutes of moderate to vigorous physical activity on a treadmill, which would be obtaining a certain percentage of their heart rate, we could see blood pressure drop substantially after their exercise. So we usually educate our patients because it could be a little scary at first when they see their blood pressure increase during exercise and they ask us, is that a normal response? Shouldn't my blood pressure be normal? Well, with the exercise, we obviously need more blood to circulate throughout our bodies to power our muscles, and our vessels dilate during our exercise. So when our patients stop and they rest, we see a blood pressure come down, and that's because of that post vasodilative effect that occurs after the exercise. So we educate the patient and we encourage them to participate in exercise every single day so that we have this long lasting effect of a certain chemical that allows our vessels to dilate to be a little bit more long lasting and a more of a chronic effect. Let's see. I hope I answered your question, Dr. Goldfinger. Was that what?
You did, but now I have a twist for you.
Sure.
Today, I don't know, this must have just been today. I had a collection of people with knee issues, hip issues. It was like the people who can't do treadmill, can't do bicycle, don't have the 8 feet clearance of a rowing machine in their apartment. What is your cardio for those?
Well, if they have access to a pool, we always recommend some water aerobic exercises because it takes off all the load bearing weight on the joints. If you don't have access to a pool, you can do some seated exercises like marching in place. You can do some, there's different ways you can trigger your body to get into an aerobic state of exercise, and it doesn't necessarily have to be the traditional walking or biking. So a combination of certain resistance training exercises like bicep curls and a shoulder press and some sit to stands and leg extensions. If you devise an exercise routine that you continuously are doing something after each exercise, you can actually engage your body in some aerobic. You can put your body into an aerobic state and you can achieve the benefits of exercising aerobically by doing something like that. It doesn't necessarily have to be on a treadmill or a bike.
I feel like Janet always has something to add on this. I feel like she's cooking something. What were you going to say in terms of your hot tip? What's the hot tip?
Well, I think I get that. I get that statement that, I have a bad knee, I can't exercise. And so I do encourage, like Frank said, upper body exercises. So doing something is better than doing nothing. And if someone says that, I have to do 6 weeks of rehab for my knee, they're doing the physical therapy part is just working on the knee, but it's not working on cardio.
Yeah. Cardio.
Out of doing exercise for 6 weeks is a long period of time, and people then their other muscles get out of shape. So I really try to encourage them to do, to look either, to see one of our exercise physiologists for information, or to seek with their physician what they can continue to exercise. Because, if anybody gets out of a routine for 6 weeks, it's so hard, at least even for myself, to get back into it. So you've got to keep this up all the time for benefit.
Yeah, and that's a good point, Janet. And sorry to interrupt Dr. Goldfinger, but we do encourage our patients to slowly increase their levels of activity at home. They don't necessarily have to start at the recommended 30 minutes a day. For a lot of our patients, we educate that there is a certain level of pain tolerance that's okay to exercise with. Anything on a scale of from 1 to 10 above a 7 of pain, we tell them to stay away from. But if you have a discomfort level of 4 or 5 and you can tolerate that pain while let's say you're trying to walk around a little bit, that's okay. And like Janet mentioned, some is better than none. And if it only is 2 minutes that you can, walk around before the pain starts setting in your knee, well, then that's 2 minutes you can do throughout the day. Let the pain subside, then do 2 minutes later on in the day, and then you slowly add that on 1 minute every week. And some of the tips we give to our patients who do have those types of complaints, we tell them to ice the knee after your exercise or activity to help decrease the swelling or whatever it is that's causing pain.
So one of the things maybe Dr. Goldfinger, you can go through that I hear from patients is, well, why do I have to be on so many blood pressure medications? I mean, I already, I'm already on one. How come I have to be on, three? Can't we just, stick with one? So why, give the little back.
It is a great question. So most people, and probably most people will find this surprising, most people need to be on 2 medications in order to control blood pressure. So being on one medication and controlling blood pressure is actually the exception, not the rule. And so once you're getting into the world of choosing a medication, so the goal is to get under 130, top number under 130, bottom number under 80. And in picking the medication, you're trying to sort of balance the good and the bad. So when I say balance the good, a lot of blood pressure medications do something else. And so you're always thinking, let me look not just at the blood pressure, but look at the whole patient and what else can I do? So a great example would be like the world of hydrochlorothiazide and chlorthalidone. So those are diuretics. They take off a little extra water. So if you have somebody who has some ankle swelling, you might say to yourself, ooh, this is a person where in addition to treating the blood pressure, I could help a little bit of swelling. In the world of beta blockers, which would be like Bistolic, which is nebivolol, bisoprolol, carvedilol, those medications also slow down the heart rate. So if you're seeing somebody whose heart rates run high, which is very common in people who have diabetes, in some people who have thyroid issues, you sort of kill 2 birds with 1 stone because you also help control the heart rate. And just as a shout out to Frank, people whose heart rates run high tend to have trouble with exercise capacity. Because if you think about it, if your resting heart rate is 90 and you're pushing yourself to exercise, you very quickly will get to a heart rate of 150, right? So your heart rate will increase by 60 points relatively quickly. If you start out with a heart rate of 55 and you do the same amount of exercise, your heart rate gets to 115, you still have more room to go, meaning you haven't reached a point where your heart is beating so quickly that it limits your ability to exercise. So sometimes that's a win. Many of the medications that we use in the ACE inhibitor or ARB category, and I'll name the common ones because I'm sure somebody is on them, lisinopril, quinapril, ramipril, those are the ACEs, and then the ARBs are losartan, telmisartan, valsartan. Those medications also protect the kidney, and also for people who have weak hearts, help protect the heart. So, just looking at the whole patient, you may say to yourself, oh, this is a patient whose blood pressure is high and they have diabetes. I want them on one of these medications to protect the kidneys anyway. But to get back to the real question, which was, why can't I just take 1 pill? So what we usually try to do is minimize side effects and maximize benefit. For most blood pressure pills, as you go higher on the dose, you increase the side effects. So usually the balance that gives you the medication works. It gives you some side benefit. It won't give you too much of a crazy side effect is some small to medium dose of one with some small to medium dose of another. In people who have very hard to control blood pressure, that's a whole different world where you'll often end up on 4 or 5 medications, usually with a diuretic, because the effect of the diuretic meaning a pill that makes you lose salt plus water, losing salt plus water often helps other medications work better. But I hear you, that conversation is often a difficult one. Nobody wants to be on medication. Nobody wants to feel that they're on more medication than what they need to be on. And probably with blood pressure, the biggest problem is that, so let's say somebody has a high blood pressure, you put them on medication, the blood pressure is a little better. Then you say, okay, we're really not where we need to be to prevent all of these bad things. And then you add something else. Sometimes people sort of get this sense of, is this really giving me an incremental benefit? And I encourage everyone, if that is your concern, to always talk to your doctor, because what I find is if people don't see a benefit of what they're taking, they're not going to take it. They miss a dose, they take it later, and you want to feel that you and your doctor are on the same page in terms of understanding what the medication is adding. Other questions that I get all the time are, how do I know that this medication is still working? the answer is usually because your blood pressure is controlled. But, I get it. And every once in a while, I'll have somebody come in and say to me, as happened today, I really wasn't believing that my medication was still working for me. So I stopped them for a few days. And you know what? My blood pressure went up. And I said, that's what I would have expected. But not in a way that was dangerous. I actually felt that was a good teachable moment, because let the person understand, that's also sort of the flip side of why I like everyone checking their blood pressure, because then you learn. The first time that somebody says, oh, wow, last night we all went out for this crazy Italian food meal and I had, 25 pounds of salami. I couldn't believe how high my blood pressure went. I don't cry in my cookies and say, oh my God, this person ate salami. It's like, yes, you get it. Or, the other version, which is, oh, this happened today too. Today was a good blood pressure day. Oh, I went out with the boys and I had 6 beers and I haven't really drank like that since I got married. So I checked my blood pressure. It was really high. It's like, yes, I thought alcohol lowers blood pressure. It's like, well, alcohol lowers blood pressure when you're drinking. Like that warm feeling you're getting is what Frank was describing of like the blood vessels opening. But people who drink more have higher blood pressure. It's like, yeah, that's exactly what happened. It's like good to know that the system works. And actually also what you were saying in terms of people watching their blood pressure go up with exercise, but go down after. It's like a useful experiment on yourself to say, oh, my system, works how it should work. I don't know, Janet, was that like long story long?
So I have a question. So if someone has medication, blood pressure medication that is only once a day, does it matter if they take it in the morning or before they go to bed at night?
So this is controversial, which I guess is why you're asking. So a few years ago, a study came out that suggested that people who take their medications at night do better and have better control of blood pressure. And it probably is because most people's blood pressure is highest in the morning. And so if you take it at night, the medication is already in your system and covering that morning spike, right? That was the mechanism and the rationale, and it makes perfect sense. The criticism of the trial was that the patients were very carefully selected. They excluded all of these different people who were taking their medication. There was sort of, I guess, some statistical manipulation. So in the end, we don't actually have great data, but I do tell people that I think there is a benefit to taking medication at night. The benefit is exactly how that idea of having the medication in your body so you never have that morning spike. A good number of people have a lot of trouble remembering to take medication at night. So most people are more regimented in the morning and less regimented at night. People who are more regimented in the morning, I say, you know what, take it in the morning. The difference in blood pressure is less significant than, missing a pill. It's like that guy, right? C. Everett Koop, the Surgeon General, who said medications only work if you take them. So remembering to take them is big. And that, the world of pill boxes, I have patients who keep their medications next to their toothbrush because they know they brush their teeth, but otherwise they won't remember. People who keep their medications next to their bed because regardless of how their day is different, at least they go to bed at night. But I guess that's sort of like the half answer, which is there may be a benefit to taking them at night, but only if you're somebody who will consistently take them at night.
Mm-hmm. Okay.
So Dr. Goldfinger, we have a beta blocker question here. I am 61 years of age. I had an angioplasty with stent recently. The cardiologist doubled my dosage. It's just Toprol XL, standard release, from 25 milligrams to 50 milligrams. Is this normal for heart disease patients?
Very normal. The most common dose that people are on is the 50 milligram dose. So that's more common. Not to whatever. And part of the reason is when you get to the 100 milligram dose, which is the next dose, some people develop erectile dysfunction. So most cardiologists will stay in the 25 to 50 range in men and try not to go to the 100. If you ended up needing more beta blocker, most people would try to do 50 twice a day, as opposed to increasing you to 100 purely for the erectile dysfunction issues. So the way that metoprolol works, or the things that it does, it lowers blood pressure it lowers heart rate more than it lowers blood pressure. It decreases how hard the heart has to work. And there's also a benefit in people who have heart failure or a weak heart. So, oh, and I should add on another one, and also in people who have had a heart attack. So I don't know if your situation was a heart attack situation. Being on a beta blocker for 3 years after a heart attack prevents death. So if you fall into any of those categories, if it was a heart attack, if the heart is not quite perfectly strong, or if your heart rates were running high, that would be a good medication to use. And going from 25 to 50 is usually a good move.
Thank you.
So once somebody is on blood pressure medication, right, then what? So usually then nothing, right? You stay on the medication, the blood pressure is checked from time to time. You know, if it's something that has a side effect, you monitor for side effects. And then one of the big questions that came up this week is, we used to say that people who have high blood pressure are at higher risk for cardiovascular disease and should take a baby aspirin. But part of the conversation that started this week was, if somebody is over 60 and has never taken an aspirin before, the risk of starting an aspirin may outweigh the benefit in people who are quote unquote low risk, which seems to be the I just have high blood pressure group. So there hasn't been a formal response yet because these recommendations are not final. But it is, you know, sort of this question of how much does aspirin benefit people? For example, the isolated high blood pressure crew. Throw that controversy out there. And then, you know, we're sort of talking or treating like all blood pressure is the same. So the clues or the things that point to what's called essential hypertension, not essential meaning like you really need it, but essential meaning like of the essence, our family history. So blood pressure can be very genetic. If you have 2 parents who had high blood pressure, you're much more likely to have it. If you have 1 parent, you're more likely, but not to the degree of 2 parents. So when people say, oh, I'll probably end up with high blood pressure because my parents had it and my grandparents had it, you're not wrong. And for those people, there's an even bigger emphasis on really starting good habits with healthy eating and exercise young so that you never get to that point. Or if you get to that point, you know, you need 1 medicine instead of 2, or 2 medicines instead of 3, or 3 instead of 4, but in some way limit the impact. There are other weird things that can cause high blood pressure, like the thyroid being off is probably the most common one. Vitamin D being very off, vitamin B12 being very off, and then stranger things like blockages in the arteries to the kidneys, some genetic conditions, tumors that secrete hormones. And I'm bringing these up not to scare anybody, but you know, if somebody is, let's say, 55 or 60 and is diagnosed with high blood pressure, we would say, okay, that makes sense, right? You're sort of in the age and your parents had high blood pressure. It's a very different conversation when I see a 22-year-old who all of a sudden has high blood pressure. You know, then we sort of go down the road of, is she on birth control pills? Does she smoke cigarettes? Is there cocaine use? You know, you look for these things that would better explain somebody who's too young to have high blood pressure, but does.
So we do have a couple of more questions that came in. The first one, why do some blood pressure medications, for example, Isoscerbite, sometimes cause neck pain and headache?
Okay, so Isoscerbide, which the full name of is Isoscerbide mononitrate, and the trade name is Imdor. So all nitrates that are designed to be long-acting nitroglycerin. So nitroglycerin, like the little pills that you put under your tongue when you're having chest pain. The way that they work is by opening up blood flow. And I mean, this is strange, but when you take a nitroglycerin, one of the ways that you know that it's working is that you feel the headache, meaning that you feel it opening up the blood vessels and you get a headache. The point of the long-acting ones like Isoscerbide mononitrate or dinitrate is that you're trying to limit those kinds of side effects. But in people who have it, you're sometimes a little bit stuck, meaning it really is the mechanism of how it works. If you're on a low dose, it might just be that that's not the right medication for you. If you're on a higher dose, you may want to try to decrease it. But it is how those nitrates work. Sorry.
Mhm. So I think this is from the same person, but is high blood pressure reversible? What's the remedy? Can yoga, Reiki, Ayurveda, I think I'm saying that correctly, cure it
You said it.
permanently?
So it depends on the cause. So let's say you're somebody who's very overweight and you have no history of high blood pressure in your family, and you spent COVID eating donuts and sitting on your butt. I'm not looking at anybody specifically. I'm just saying they're out there. And you show up at Goldfinger's office after not seeing a doctor in 2 years, and all of a sudden your blood pressure is 150, right? That is not a person who I would slap 2 medications on and, pat them on the back, right? That's a person who I would say, listen, get it together. What's with the donuts? I know a Krispy Kreme open around the corner. For everyone who lives on the east side, a Krispy Kreme open around the corner from me. Awesome. Haven't been there yet. No, but that's somebody where you'd really be aggressive. In somebody who's in their 50s or 60s, has had high blood pressure for a while, has a strong family history, we're more focused on controlling the blood pressure to prevent outcomes and less thinking that that's something you can get rid of. It's always worth a try. Now, the specific things that you're mentioning, like Reiki, etc., if there's a component of the blood pressure that's related to stress, tension in the body, all of those things will help. Acupuncture, massage, Reiki, etc., right? And sometimes people have varying degrees of awareness of how much tension they carry in their body. So it is worth a try, but it's hard to know without seeing the sort of the full story, how effective that will be.
Thank you. And we have another one that came in. So this is a little bit of a longer question, and
I'm ready.
not so much of it's a question, more of a statement or a comment. The problem with taking the medicine at night is going to the bathroom all night. I'm on hydrochlorothiazide once a day in the morning, but I feel like what you said, I'm overweight, so just walking will put my pressure up. So I need to sit a little for it to regulate when I take the medication. I feel shocking sensations in my arms and shoulders. I have to go in and talk with my doctor about this. I want to take pressure medication if I need to. I just hate going to the bathroom so much. I already go to. And this is 25 milligrams, age 45. So I wonder if that was his dose. Yeah.
So hydrochlorothiazide is a diuretic. It will make you pee more. And I'm glad you mentioned it because I should have mentioned it and I didn't. That is not a great medication to take at night, because then if you end up peeing at night, that's going to disrupt your sleep, and then poor sleep doesn't help the blood pressure anyway. So that would be a medication better to take in the morning. It sounds like with that feeling in the arms and the shoulders, it may not be the best medication for you. I don't know if maybe the potassium is running low, because hydrochlorothiazide causes you to lose potassium. And maybe you're sort of feeling like that weird feeling from muscle aches from low potassium. But I think that might be somebody who should speak to their doctor directly and address their concerns, meaning you can say, listen, I'm peeing all the time. I want my blood pressure better, but I also want to, function. Can we try something else? And it's not like, you throw it in the garbage and it goes away. It's more like, okay, let's try something else for a month or 2 months, see if it works better, see if it's more agreeable. So I'll tell you, I saw a woman today was on valsartan for a long time, and her blood pressure was too high. And her doctor put her on hydrochlorothiazide and she became very dizzy. So, I don't know. I feel like if I told my mother, who was a kindergarten teacher, the story, my mother would say, okay, stop the hydrochlorothiazide. It made her dizzy. But instead, what happened was her doctor told her, okay, drink 24 more ounces of water a day. Okay, take potassium pills, right? So now she's drinking all this water, taking extra potassium pills, and she's still dizzy. So, I just said, okay, how about we try stopping the hydrochlorothiazide and trying something else? And her blood pressure was better. So I'm not from that perspective, it was a good move. And I understand that primary who's probably thinking, oh my God, this woman's blood pressure was so hard to control and we got it. Okay, but we got it, but this person has to live, and quality of life is so important. So if she's so dizzy that she's not exercising, and there's something missing. So I think your question points to that, right? There's some benefit to you in having the blood pressure controlled. Maybe that medication works on one level, but maybe it doesn't work on another level. And the good news is there's so many medications, and some of them are generic.
So we have another question that came in. I'm on metoprolol and recently had an increase to 50 from 25. I went to the dermatologist because, yes, this is another person.
Okay.
I went to my dermatologist because my nail was separating from the nail bed, but started to heal. He said there is literature about psoriatic something, sorry, I can't remember the exact name of this condition, with the nails and metoprolol. Was this from the increased dose, or was this from being on the med for nearly 5 years?
I really don't know.
That's a head scratcher.
I could fake look it up, but I really don't know. I don't know about metoprolol causing nail separation. In some people, it causes hair changes. I don't know. Janet, do you know?
No, but I'm going to see if I can find it now. I'm looking.
So we'll try and find an answer for you and hopefully get back to you on that one.
My take is if something new. Wait, sorry, I'm back. That was my child calling me. My take is if you have a change in medication and you develop a new whatever, assume that it could be from the medication, but a nail thing specifically, I just don't know. Sorry.
Okay. So here's another question. I have problems sleeping and do get up several times to go to the bathroom, so I'm up longer. I was told to take melatonin, but the warnings are scary. I take metoprolol, spironolactone, and atorvastatin. Can I take melatonin?
You can take melatonin. Melatonin is pretty safe. Here's the scoop on melatonin that I learned from a sleep medicine doctor. For melatonin to work optimally, you are supposed to take it 4 hours before you plan on falling asleep. And it does not kick in then. So it's not like you're going to take it at 5 p.m. and drop. But if you take it, then by the time you're planning on going to sleep 4 hours later, it has your body more amenable to falling asleep.
Wonderful. Okay.
Who knew?
We having a lot of questions tonight. I love this.
Yeah.
What's the normal
sleep? I want to talk about for just a minute. Sorry, but hold that thought. Don't lose that question.
Go ahead.
So sleep apnea, which is common and not always diagnosed, which is a condition where people effectively stop breathing at night, often because of soft tissue in the neck. Sleep apnea is one of the risk factors for high blood pressure. And treating sleep apnea can help treat blood pressure unless you've had it for a very long time. The way that it increases blood pressure is because your body becomes aware that you stop breathing. Your body releases this huge surge of adrenaline to wake you up, and having these repeated surges of adrenaline at night increase your blood pressure over time. So somebody who wakes up a lot at night, unless it's you're waking up because the spironolactone makes you pee or whatever, tucked away, I'm thinking, do we need to be concerned about sleep apnea? So the questions would be, do you snore? Do you wake up and still feel tired? Has anybody who has slept with you ever told you that you gasp or stop breathing in your sleep? And if any of those things are true, you might want to think about being evaluated for sleep apnea. Okay, you were going to say, and then we have to give Marnie something because she's waiting.
Okay, so we have this question. What's the normal lower blood pressure? With medications, my blood pressure tends to be low without symptoms of dizziness. How low
That's
is
for
it?
Marnie.
Okay?
I'm joking. Okay, so that is a great question. So normal blood pressure, we're aiming for under 80. There is not great literature on what's considered too low. And I will tell you, When I was a resident, we were told if the bottom number goes under 55, it's dangerous. That turns out to be a myth. So in this group, so this wasn't exactly done as a study, but this group of researchers took many blood pressure trials and put them together in what's called a meta-analysis, which is where you try to learn a big lesson by trying to increase how much data you have by putting different trials together. And basically found that there is no increase in risk of having the diastolic go as low as the 40s. There may be some health risk when that bottom number goes into the 30s. For me, this is all very shocking because, like I said, when I was training, they told us don't let it go under 55, but there is no real risk there. So if the bottom number goes down into the 40s and you feel okay, you don't need to worry. Crazy.
Wonderful. Okay, we have another one. What causes hair changes? I'm losing hair as well, and my nails are very rigid.
Okay, so stress is the number one cause of hair loss. Sorry. I know nobody living in New York in 2021 has stress, so what could that be? And the worst part is, as Dr. Mechanic will tell us, our endocrinologist, it takes 6 months till it starts fixing itself. So if you're having hair loss from a stress-related issue, it's 6 months till it starts growing back. This is what I tell people. See a dermatologist. Some dermatologists don't really handle nails. They'll make you see a dermatologist who specializes in nails, but see a dermatologist. They can sometimes, by the pattern of the hair loss, tell you if they think it's a medication, if they think it's stress, if they think it's something else. It's never normal to lose hair in patches from around your head. There are some types of hair loss that are hormonal, and that's the thing. COVID made people lose hair. So if you had COVID, that'll do it. And it takes a while to grow back. Hormonal changes like having a baby, etc. You can lose hair, gain hair, and then lose hair. But stress is a big one. There are medications that can cause hair loss, and usually the hair loss will be tied very closely to when you went on the medication. If you've been on something for a few years and you started losing hair, I would not blame the medication. But again, if you're worried, see a dermatologist and see where it goes. And if there is hair loss that's even from stress, because this I didn't know, there are different medications you can take. Some of them actually lower blood pressure, like Rogaine, which is minoxidil. Minoxidil is an alpha blocker, so it's a blood pressure pill. But the dermatologists now do injections of steroid directly into your scalp to help with hair growth. Who knew?
Okay, we have another one. Probably time for maybe one or two more questions. Is there medication to cure sleep apnea? Is that reversible?
Okay, so sleep apnea doesn't have a medication yet. For most people, it's treated with a machine called a CPAP or an APAP, which is continuous, or I don't know what the A stands for, positive airway pressure. You've seen them. It's like a mask with a hose. And what it does is it blows in air so it doesn't let you stop breathing. The reason that most people are treated with that is because every insurance covers that. And so usually people will go on the option that's most affordable, which is the option covered by insurance. There are other options that are not always covered by insurance that are maybe a little bit more sexy or like less unsexy, not to call CPAP unsexy. So there are what are called oral appliances. They look like Invisalign or like a kid's retainer, but with a hinge. And so what the hinge does is it connects the top and the bottom, so your bottom jaw can't fall backward while you're sleeping. So it prevents that effect of the bottom jaw falling backward. Newer things, there's a device called Inspire, which looks like a mini pacemaker implanted in the chest that has an electrode into the throat. So you don't see any of it. It's all internal. And it sends a little pulse of electricity that if you're going to stop breathing, it forces you to breathe. All of those things work, but they're not all covered. But in terms of a pill, no. More often than having sleep apnea that requires treatment, the reports will say, patient has mild sleep apnea. Consider having the patient sleep elevated. So if you go on Amazon, they call them a sleep apnea wedge. It's like Sorry, it's my kid again. Sorry. So the sleep apnea wedge is to keep yourself elevated so that your jaw doesn't fall down. And usually it will fall back. They'll also usually say recommend weight loss and avoiding alcohol before bed. Alcohol before bed is a big trigger for sleep apnea. So somebody who has mild sleep apnea and they drink before bed, the sleep study will look moderate. Somebody who has moderate sleep apnea, it can look severe. And the problem is, or the idea is, alcohol is a respiratory depressant, meaning it makes you breathe less. And so if you have a little bit of a problem related to breathing at night, it will give you a bigger problem. I'm not saying drink in the morning. I'm just saying don't drink before bed. So I guess that depends on your life situation when you're gonna fit in the drink.
Oh, Dr. Goldfinger, thank you so much. I believe that's all the time we have for tonight. I don't see any more questions. I think we hit a record for tonight for most questions answered by any presenter. So congratulations.
Thank you.
So thank you so much for your time tonight. We do hope that everyone here was able to learn something on hypertension and detecting, correcting, and protecting. So I'd like to make an announcement for the end of the month. We will have Monica Jane. She was our last presenter who did mindfulness. She will be covering her part 2 on Wednesday. I believe that's October 26th. I'm sorry, October 27th at 6 p.m. So it's going to be an hour earlier than what we usually have our webinar presentations. I want to remind everybody that there is a survey at the end of this webinar tonight with a couple of questions and an open text box for you to, I'm sorry, someone's calling me. Just I'm trying to call
Is it
us
my
right
kid?
Now. Yeah, I think so. You might want to call them back as soon as this is over. So please feel free to provide any comments, questions, concerns, or your email so that we can get back to you on any questions that weren't able to address tonight. So with that, Dr. Goldfinger, thank you. Janet, Marnie, thank you so much for attending. I hope everyone has a good night.
All right. Good night.
Bye-bye.